Good morning all. I am Brijesh. So I am discussing a case which has caused me lots of anxiety over the last 2 years. So this is a 51-year-old gentleman. He's from Maharashtra. He comes to us with a history of being a pre-diabetic for a long time, for 4 or 5 years. And under my care also his HbA1c has been maximal around 6.2% with fasting glucose levels hovering around 115 milligram per deciliter. So I've checked this again and again over the last 2-3 years. His left eye had macular edema, which was significant, and he had been treated prior to coming to me, and we also treated twice with both steroid implants as well as anti-VEGF injections, as well as a session of focal laser. It was kind of controlled. So he's okay. Left eye vision is slightly low, but he's okay. Unfortunately, his right eye started progressing. So if you see the dates which are mentioned, 30th of January last year and then 23rd of January this year, we find that slowly macular edema is happening again to the other eye also and encroaching the center, even though the vision remains same. CMT was 310 in the bottommost panel, if you see my cursor, and this is the cystoid space coming up. So the question over here is, how should I stop or how should I prevent the right eye from having the same fate as the left eye has had? So I went on through the literature, and if you can make out these graphs, this graph over here is from a systematic review which was looking at the prevalence of diabetic retinopathy in pre-diabetic individuals who have never had diabetes. And it seems that the median prevalence is around 7%, whereas for our region, which is Southeast Asia or India, the prevalence is much higher, 18%, 19%, something of that sort. And the forest plot over here shows the individuals who can develop central macular issues even in presence of pre-diabetes and not in presence of diabetes. So the question over here is, I send this patient to the endocrinologist who says that I will not give OHS because the patient may just collapse, he has normal sugar levels. I have no way to stop the right eye from progressing, and we look at if we have some alternate ways which can stop DR from progressing even in pre-diabetic stages. And definitely there is something other than hyperglycemia which has a role in this.
Thank you, Dr. Brijesh. What do you think is the cause? I mean, is it really diabetic? Because we know that these type of diseases can have a different expression. That means some of the diabetics may have kidney problem, others may have eye problem. So is it because the basic pathology is hypoxia? Is it something else causing hypoxia, or it is the expression of the diabetes itself? What is your opinion?
So over the last 2 years, Dr. Lal, I've gone through all kind of tests, whether it is inflammatory disorders, connective tissue disorders, the general testing that we do. And he's with me for 2 years, so I have, gone through that passage as a doctor-patient relationship. So he is a hypertensive also, he is a dyslipidemic also. There is a metabolic syndrome which is happening over there. And I believe, I personally, I don't have any proof to, any evidence to support this, but I think this is a metabolic memory which has developed in him over the years.
Do you think it has any correlation with the HbA1c level or any other indicator by which we could predict?
Yes,
that,
doctor. So
which
last year when we treated him, his HbA1c, sometime, it came to 5.8, 5.9.
That is
after using Diabetic ATA and certain neuroprotective agents, which I, got him to use after in conjunction with a neurologist. And at that time, his left eye, the CMT came down by itself. So obviously that relationship is there, but in conventional ways, how do I prevent the right eye from worsening? I can't give OHS.
So I think a long time back when I was postgraduate, and at that time Michelson and Ballantyne book of retina was very popular. So they said, they described the retinopathy because of hypoxia, which may be the causes may be in the wall like hypertension, in the blood like in the serum like diabetes, or sickle cell anemia, or in both, in many. So they enlisted around 15 causes or so. So the basic is that the hypoxia is the main culprit for development of this edema, and whether it is actually diabetic expression or something else is happening which we are not investigated as of yet. So anyway, thank you for bringing up a wonderful